Hello and welcome to For Vaginas Only, the podcast about everything female. I'm your host, Dr. Celestine, bringing you important information about understanding your health and body in the way you wish your doctor would actually explain it. Hey guys, so I thought I would just do a little quick intro to this podcast turned YouTube video that I'm about to present. It is an interview I did with Dr. Tiffany Jones, who is a fertility specialist in Dallas, Texas, and we talk about all things from the menstrual cycle to ovulation to what she does to help people get pregnant and about the disease of infertility. It's a great conversation. I just wanted to introduce it first before we hop right into the video. Well, welcome to the For Vaginas Only podcast. I'm so glad to have you. I'm glad we could connect.
Yes, so nice to meet you.
You too. So for everybody that's listening, Dr. Celestine, as you all know, and with me today I have Dr. Tiffany Jones. Tell us a little bit about yourself, where you work, and let the listeners hear about you.
Yeah, so I am a reproductive endocrinology and infertility specialist. So basically, I'm OB-GYN trained, and then I did a 3-year subspecialty in infertility treatments. I am board certified in OBGYN, and I hail from Los Angeles, California, and I practice in Dallas, Texas. So after my residency in OB-GYN at USC, I went to Mayo Clinic in Rochester, and then my boyfriend, who I call my Stedman because we've been together since medical school, so that's about 13 years ago now.
Wow.
His family's here, so we decided to take roots here because there's no state tax and California is really expensive.
Yes. I actually moved from West Virginia to New Jersey recently, and my husband's like, it's way more expensive here than it was in West Virginia, so he's like cursing me. So today on the podcast, I really wanted to talk about some stuff that might seem basic to us, but one thing that I've realized a lot with the For Vaginas Only podcast is that, well, the reason why I do it is because things that seem simple to me, everybody doesn't know, and everybody should know and have at least a basic understanding of it. So first and foremost, we're talking about the menstrual cycle, we're talking about getting pregnant, we're talking about how a reproductive endocrinologist and infertility specialist can help you with those goals if you're having issues. But I like to start really from the beginning. And talk about what exactly is a normal menstrual cycle. Like, just because your friend has, a 28-day period, you have a 21 or 22 one, doesn't mean it's not normal. So I always reinforce that a normal menstrual cycle can be anywhere from the 21 to 35 days. But what do you talk about when it comes to the menstrual cycle and what's normal for your patients?
So I generally have to start from the basics of, what it is. I don't think we get a lot of good health education in our school system. So a typical cycle, we like to use 28 days. And so when you hear something like that, or when we use terms like normal, people don't understand that there's a normal distribution. So like you said, 21 to 35 days is within the realm of normal, and whoever falls outside of that interval may have periods that are too frequent or too infrequent. But I have to start off from it on a hormonal level because that's kind of what I do, and just explain to people how a cycle happens and why it being regular, whatever that time frame for you, is important. So typically what I say is that, our system is regulated by the brain, as all of our systems are. And there are hormones in the brain that stimulate the ovaries, which lie in the pelvis, to produce other hormones that act upon our uterus. So I did bring my models because I love think that, let me tell you, we taught, like, I am, I'm not an artist, but I'm sensitive about my stuff. Okay. So
I'm always drawing, and I'm not an artist.
So I draw, but like I said, I'm not an artist, so you're gonna work with me. But I brought my models with me today. So this is my little Yudi model. So hopefully this shows up for your viewers well.
Yeah.
But pituitary gland in our brain, and that gland secretes hormones like follicle stimulating hormone and luteinizing hormones. And basically in the ovary, which is here, the ovary is secreting estrogen and progesterone and testosterone, so hormones that can regulate the cycle. So estrogen is the most important part of growing the lining, which this is the uterus here. And the inside of the uterus is where the endometrial cavity is, and that lining grows every month, and it's growing all in preparation for pregnancy. And so if a pregnancy occurs, the lining will sustain itself, but if it doesn't, a new cycle will commence to prepare us for pregnancy again. So estrogen starts to elevate it early in the cycle because of the follicle stimulating hormone. And once the estrogen reaches a threshold, an egg will be released from the ovary and travel through the fallopian tube, and maybe it's met by sperm, maybe fertilization occurs. But if it doesn't, then the progesterone that is secreted from the sac that's left behind once an egg is ovulated, that will go away. And so as estrogen is what maintains or what grows the lining, progesterone maintains it. So progesterone is and we call it progestation, so progesterone. So if it's not needed anymore and it goes away, then so will the lining. And so then the lining will shed through the cervix and out through the vagina. And that happens every cycle if a cycle is regular. And how we get irregular cycles is something is not happening during that time. Mainly that I see, we're not releasing an egg, and then there's no progesterone, so there's nothing to maintain this lining, and so it's truly not a cycle.
Right. Or the issue, or if you're having a hard time becoming pregnant, can happen at many different points along the way.
Yes.
So that's what's important to know. And it's nice to see that image. So anybody that's listening to the podcast, if you don't know, I do have a YouTube page, and you can see what we're pointing to. You can see the diagram, and it helps visualize this just a little bit better. Yeah. So that's great. And ovulation, right? So when you say that's the most important or the most common reason why you see someone having issues becoming pregnant, is they're not releasing that egg. So why is it important to ovulate? What actually triggers ovulation? What are the hormones that are important for ovulation?
So what triggers ovulation is a surge in the luteinizing hormone, which is also coming from that anterior pituitary gland. And and there is a threshold of estrogen that is reached. And then the body knows that there should be an egg that's ready to be matured. And so once that estrogen level that is reached, that threshold, then the luteinizing hormone that surges. So when women are tracking their ovulation on those home kits, they're usually tracking their urine for LH or luteinizing hormone. And it starts off very low. It's just very low. And then it just skyrockets. And about 36 hours after the initiation of that surge, an egg will be released.
Okay. So speaking of the ovulation predictor kits or OPK kits, if someone was trying to use them, trying to get pregnant, what do you recommend? How do they use them?
I recommend they follow what the box is, okay?
That's what I say the same thing. That's so funny. Can
you read the box, please? Because I'm like, it's, generally it's the first void early morning. And I typically tell my patients to start around cycle day 10. There are some newer kits that I actually really like. It's unfortunate that they're expensive, but they're not colorimetric, meaning that they actually give you a number. A lot of these kits are a happy or a frowny face, a plus or minus, or it's shades of blue.
Right.
And that I get all these sticks. They're like glued to a piece of paper, and then it's like, oh, I ovulated that day. It's like, these sticks all look the same to me. So I know it's frustrating to the patients. But some of the trackers now give you an actual level. So it'll be like 5, then it's like 30. So you've surged.
Yeah.
But I do think you have to follow the manufacturer's recommendation. But when I am telling people when they should start tracking, it's usually about cycle day 10, because, even if you're a shorter cycle, it's, the surge really shouldn't happen before that time. And you're really trying to see when the surge happens. You don't want to catch it at the peak, because then you're really not going to be able to say, are you going to ovulate in 12 hours or 24 hours? You're trying to start at that initial part of the surge where it's the onset.
Yeah. And then when do you recommend that people start to have intercourse, whenever they see that surge or begin to understand when that surge happens for them?
So I typically tell patients, if it's at all possible, around cycle day 10 to start having sex every other day, especially if you're doing this just at home without, any input from your OB-GYN or from a fertility specialist, because, in a shorter cycle, let's just say if you have a 21-day cycle, you have to subtract 14 days from, when you got your last period to figure out when you're going to ovulate. So if you're around day 10, a 21-day cycle is shorter. So that's kind of like around day 7, but typically most people ovulate around day 14. So if you start around day 10 and sperm is in the tract for about 3 to 5 days, you're just kind of replenishing it so that there's sperm there to meet the egg when you do ovulate. Some couples can't do that, of course, because of work, you're tired, somebody's out of town. But typically, if it's possible, that's a really good strategy, because that's kind of your fertile window.
Okay. I always tell my patients that as well. I usually use day 9. I don't know, when we were training, that's what I had always learned from my RPIs. But it's a similar concept. So it's interesting. I guess it's more of a personal question. So it sounds like you like the ones better with the ovulation predictor kits that have the numbers.
So I personally don't like ovulation predictor kits. It's just like, it makes things like a science project. And when I'm working with fertility patients, things that we don't get into enough is like the lack of intimacy between the partners when people start to try to get pregnant. Really, I understand, like, women want some control, and doing those things can be helpful to some people who just want to like make sure and double check. But really, it's just, if you have sex at the right time, then you're going to catch it. Just like me doing an ultrasound. An ultrasound doesn't make you ovulate. It just checks to see if you are. So if you have to watch the water boiling, sometimes it feels like it's never going to come on. So I think it's a stressor. But why I like, if I had to pick one, and I don't promote for any of those trackers, so I haven't used their names, but I do feel that, especially like if you think of polycystic ovary syndrome patients, the people who probably need them the most, well, their basal LH or baseline LH is higher. So you might have a positive all the time, and they come, Dr. Jones, well, I ovulate. Well, when did it turn positive? Day 9. Girl, was it positive day 10? Yes. Was it positive day 11? Yes. Was it positive day 23? Yes. And it's like, well, okay, well, that's the longest surge and peak I've ever seen. And it's because it's always going to be positive, because your baseline is at the threshold of the positive test. So in those patients, it's very wasteful of resources to continuously check. And, and then on the other side, there's some people it never turns positive and they are ovulating. So the reason I like it to give me an actual number, because I think it's easier to interpret than a shade of blue.
No, I agree. And a lot of patients that come to me, obviously they come to me a lot of times a little earlier than they would come to you. They're just starting to try, and I'm like, and they're already asking me about ovulation predictor kits. I'm like, just have fun. Don't worry about it.
I tell people the most, and fertility, like infertility is it's a disease, right? But some people, before they even are diagnosed with infertility, it's just, you've been trying for 3 months, and it's like there's sometimes where there's a level of impatience. And so I tell people, especially when they haven't tried for very long and there's no underlying issue that needs to be addressed sooner, is most babies were probably made in the club after a night of drinking, where nobody's trying. And so it's really that when you start watching that clock, that a lot of times you just, and then you start seeing everybody else with positive pregnancy tests and baby showers and all this. So you just start to notice it. But really, if you have sex around the right time and you give it some time, most people will get pregnant if they don't have infertility, or a reason to, check for infertility early.
Is it still considered a 20% chance each month of getting pregnant? Do you guys still follow that statistic?
That's why I say don't watch that clock. Right. 20%. The opposite is the other side of that is 80.
Right.
So it's a cumulative pregnancy rate that we're looking for, and that's why we give it a year for women who are under the age of 35 with no, reasons. It's not, if you have a uterus full of fibroids, this is not a year wait.
Right.
If you have polycystic ovary syndrome and you never ovulate, do not wait a year. But if there's nothing going on, you have regular periods and there's no reason to intervene early, giving it a year, 80% of people will get pregnant within a year, and 90% will get pregnant in 2 years. So we recommend intervention at a year, or at least a workup at that point.
Yeah. And is that still for those under 35, or what's the ages that you recommend? A year versus 6 months, or versus?
Yeah. So 35 is our cutoff point. So if you're less than that, it's a year. And if you're over that, then it should be 6 months. And that's basically because after 35, if there's infertility, the treatments really matter on age. So we don't want to waste another 6 months. That could be an effective treatment with just something as simple as Clomid. So it's probably better to intervene earlier for people at 35. But again, some people, it might, I've had people start their workup and they're pregnant after the HSG. We can't even finish. So
I know.
I count that baby too, though.
Oh gosh. A lot of my friends, I'm in like that age group where everybody is getting pregnant right now. So a lot of my friends, that's happened to, they start their infertility workup and then they get pregnant naturally.
Yeah.
So, which is great.
That's a good feeling.
Yeah. So when somebody comes to you, say they've been trying for a year under 35 or 6 months over 35, and their OBGYN, like myself, tells them, I really think you probably need more specialized help. I guess, let me back up. What would you like their OBGYN to complete and to do before they get to you? That's my first question.
I think, we all do a very thorough history and physical. So that's my number one thing, because in someone's history, especially their menstrual history, you're going to pick up on cues. Like you said, if your cycles are, really irregular, you're picking up ovulation issues, if sexual frequency is not enough, then you're counseling on how to improve that. If you are asking the real good questions, like, is there any erectile dysfunction in the partner, those are things that you could easily miss because we're OB-GYNs, and that's not really something you're not going to get into people's all day business, but that's the business at hand is, we need 2 of you guys to make this one baby. And so those questions about the partner can help identify some things that need intervention. I do think that we use one of our best tools too infrequently, and that's the ultrasound. And as a Black woman who knows that other Black women are likely to have fibroids causing it, it's like, why you waiting till my fibroids get to be 10 feet tall before we find it, and you cutting me from stem to sternum?
That's so true.
Like those kind of things, I think getting an ultrasound, because that's part of my assessment, and that would be helpful. I think a lot of OB-GYNs are a little fearful of AMH. I'm not sure your feelings of it. I know
I love testing for AMH.
Thank you. But if you have a patient who is trying to get pregnant and they fall in that criteria where they're tipping over to infertility, when you refer, it's nice if I have a landing pad of, there's an ultrasound that has been done, so I can look at that, and AMH, so I can boom, okay, the AMH is low, it's high, it's normal. We can go somewhere with that instead of me doing my initial assessment, they have nothing, and then it's like this longer drawn out process when I don't have any basic labs. One of them, I'm about saving that coin. So if it's been like, if you're older and it's been 6 months, I will repeat some things. If you're a young woman and you've had an AMH within a year, I typically don't repeat it. ultrasounds we do all the time, even during treatment. So that's a likelihood of getting repeated. But again, it gives us a nice baseline conversation to start with when a woman enters my office. So I really love that. And a semen analysis for the partner. I think that's completely appropriate for a basic workup of fertility to, send the man. 40% of the time, he's at least a contributory factor. And I know it's like pulling teeth trying to get him to go do it, but it gives a wealth of information to the couple and can probably identify some people who have some serious issues early.
Agreed. I totally agree. That's usually part of the workup I do, but I'm a little bit biased. I've also had a special interest in fertility for a long time. So I feel like I always have kind of like my finger on that pulse, like what should I be doing, So it's a little bit different.
Your patients are benefiting from that. So
I hope so. So when they finally do get to you, what should they expect? Is there anything they should bring with them? Is there anything in particular that goes down in that first meeting that you'd like people to know about?
I would love it if my patients, my newly referred patients would bring their records. I mean, it's just so refreshing to start with something and to leave a doctor's office with some information, and I can educate you on like statistics and a world view, a bird's eye view of what it is at this age group or that. But it's just really, I think as a patient, refreshing to say, this is me, this is what I think about you. And having records of things that have already been done is really helpful to start the conversation at a higher level. And I think, if they do charting and things like that, that's very helpful. A lot of people use period trackers. So I think that's very helpful because one, what we remember and what is accurate are sometimes very different. And so somebody be like, oh, reflex, I have 28-day cycles. And I'm looking through that phone like, girl.
There's not one 28-day cycle in here.
You done missed the whole January, February. I was stressed. Okay. You see, that's not 28 days. Okay. The tracker saying it's 45. So somebody ain't right. And so it's just helpful in those scenarios to have that kind of information that's a little bit more concrete and not rely on your memory. Because honestly, I couldn't tell you without my tracker, how irregular my cycles are because I'm busy. It's not the best time of the month. I'm not just, and I'm not trying to get pregnant. When you're trying to get pregnant, you might be a little bit more on top of it, but using a tracker.
I tell people that all the time, even when it comes to simple things like birth control pills. I'm like, I have a hard time taking them, so I can't even imagine other people like remembering on time. So it's just
put it next to the toothpaste.
Exactly. All right. So do you do is it just counseling usually the first visit, and then what happens next?
So on a first visit, I usually do counseling. And when we were still doing first visits in the office, I did an ultrasound because again, it gives us some like, this is you scenario. And the next steps usually are some blood work if it hasn't been done. And I would say 90% of my patients don't come with any blood work. So we're doing blood work of AMH. Sometimes if it's correct in the cycle, early in the cycle, we do FSH and estrogen. They're my least favorite of doing now because it is cycle dependent. And, I just feel like it kind of slows down the workup and it doesn't give me a lot of extra information over the AMH and ultrasound together. So blood work, ultrasound, and HSG. I have made a balance in my practice. Like I treat a lot of same-sex couples, so it's really a situational infertility when it's two women. And so, in that I give an option of HSGs, although the treatments can be so expensive that you don't want to find out in hindsight once you've done a couple of IUIs. People get real mad. Your tubes are blocked and we've been doing IUI after IUI. But, if there's no history of STI, sexually transmitted infection, or if, there's no endometriosis history or, things like surgery to the pelvis that I am thinking we're going to find tubal, most of the time it's open. And so I do give some people the option of doing it, but for the most part, it's part of the initial evaluation. And then I do a cavity evaluation with a hysteroscopy. We do them in the office. And there's a very high prevalence of polyps in patients. So for infertility patients. And an HSG can give you some kind of a cavity evaluation, but
Right.
the false positive rate is so high. It's like, is that a shadow? Is that a pollen? I don't know what that is. And for your listeners, an HSG or hysterosalpingogram is just an X-ray using iodinated dye that can be picked up on X-ray. And if the dye goes in the uterus and it goes out the fallopian tubes, I know they're open. But if it doesn't go out the fallopian tube, it's blocked, or there's a tubal spasm that's preventing the fluid from going through. And so that's how we could diagnose some tubal blockage or even damage.
Right. And then a hysteroscopy is where we just look into the uterus directly with a camera and we can see what's inside of the uterus.
Yeah.
So, okay. So I know we talk about many different causes of infertility throughout this whole discussion, but what are like the top 3 causes that you usually encounter?
So PCOS by far, polycystic ovary syndrome, where a woman isn't ovulating. That's like the number one thing I see. And then male factor, again, it's very prevalent. And then the other factor is fibroids. So I'm an African-American physician. I have probably 90% of my practice is African-American women, all age ranges. And it seems like no matter, they might have said when I was training that fibroids happen, like 30s, 40s. Nah, okay. They happen early and then they get bigger in your 30s and 40s. But because I do an ultrasound, I see them. Sometimes they're a cause for infertility. Sometimes they're just like an incidental finding. But they're very, very common, especially in African-American women.
Right. Yeah. Back when I was training, I did a whole entire a research project for years just about fibroids. So, I mean, being African-American myself, obviously a lot of my family members have fibroids. Understanding the science behind it and how common it truly is it was crazy. It was interesting. And I can't believe first of all, I can't believe you have so many African-American patients in your practice.
Yeah.
It's great.
It's a blessing.
It's so nice.
I have all ethnicities, but I am the only African-American fertility specialist in Dallas that does full spectrum service. My colleague, Dr. Lisa King in DeSoto, Texas, she is a board certified reproductive endocrinologist, but she doesn't do IVF right now.
Okay.
So it's just me. And as I've built my practice, just people want to see who they want to see. And I'm very blessed to have that demographic as part of my patient base, a large part of it.
I'm sure they're so glad to find you,
Yeah, we have a good time.
Yeah,
we laugh though. But we can't share a wall with other doctors because we're in there clowning. So it's fun.
That's awesome. That's so great. So depending on, I know this might be a hard question to answer, but, or maybe not. I wanted to kind of discuss the different types of treatment options that are available, maybe starting with like what you would try first, or, why you would try this versus that, or however you want to present it. I've heard a lot, about starting with IUIs and then you can go to IVF, but I don't do this stuff. So I want to hear it from you.
So you really should be treating the underlying condition, right? So if I think it's fibroids, then I will do a fibroid surgery and then send my patient to try some more on their own because that is the diagnosis. But we can do fertility treatments even in those patients outside of myomectomies. It's just kind of really what a patient desires to do. A lot of my fertility patients want to do things as naturally as possible. It's just how they feel. And I always try to meet people where they are. So the most successful treatment option is also the most expensive, and that's IVF, okay? Some people have to go straight to IVF, be it an age issue where it's really recommended that they have genetic testing because, the success rates for everything else is so low. If they have tubal factor infertility or very severe male factor, if they have recurrent pregnancy loss and, they just want to do genetic testing on an embryo to make sure that it's normal. Those are indications why people go straight to IVF first. but it's very hard for everyone to go straight to IVF first because it's so expensive. And if that was the only treatment I could offer my patients, I don't think that I would have as many patients as I do. Okay. So the other options are, you know, if IVF is up here with success around 70% in some age groups, everything else is like here.
Wow.
Okay. And it's not that it can't work, but it's just when you think about how we get pregnant, it's a little bit of miracle and magic. Okay. An egg is one cell, it's microscopic, it's released into your body, and then your fallopian tube has to find it, or it finds your fallopian tube, and then has to go up the wrong way of a slide, which is your tube, to then meet a sperm that happened, you know, when you had sex at the right time, and the sperm swam the right way in the right tube, and then it has to fertilize normally in that tube, okay? And then it has to start dividing correctly. And I know from how we watch embryos divide in a lab that it don't happen all the time, okay?
Right.
It's a perfect, you know, perfect system. And then it has to get into the uterus from the tube and then start its implantation. First hatch out of its shell, because yes, we start off in the shell too, and then implant and grow and survive. It is not an easy thing. And what IVF does is it takes away a lot of those things and it makes it happen, right? So I make an embryo. And so, and that embryo can hatch even in the lab, and then it's put into the body, and now all it has to do is stick. Even in IVF, we can tell if something is genetically normal. So we've taken a lot of the, you know, barriers out of, you know, getting pregnant with all the things that have to happen in the body. So, and so doing things like ovulation induction, like Clomid, right? So Clomid can make you ovulate if you are not ovulating. And if that's your only issue, you would think, oh yeah, well now I'm gonna get pregnant off my first Clomid cycle because now I'm ovulating. And it's like, well, no.
That's not the only thing.
Okay.
Yeah.
It's a lot more hurt. We might release the egg, but I don't know if the egg lands by the liver. I don't know where that egg went. I don't know. No GoPro cam is that small. We don't know.
Right.
So, you know, it's a part of the battle, but it's not the full picture. And I've had plenty of patients get pregnant off of Clomid and its counterpart letrozole, or even using the injectable medications to really stimulate their ovary to release more eggs. But most of the time it doesn't work. You know, like it is in some age groups, it's like 8%, you know, after 35.
Wow.
You know, who would do any treatment that's 8% successful?
That's like nothing. Yeah.
You know, but again, I'm telling you, like if I only could offer IVF, then a lot of people would have no hope.
Yeah.
And, you know, it does work for some people, but a lot of people end up doing multiple cycles and then having to go on to something else. And that's incredibly frustrating and emotionally, you know, charging for patients, especially because the resources are often limited. The intrauterine insemination you mentioned, I reserve that for patients who have unexplained infertility, because we feel that, you know, maybe there's a cervical factor that we really can't identify, concentrating the sperm, filtering it so it's the best quality sperm and putting it directly into the uterus instead of letting it be deposited into the vagina where it has to swim up the cervix and be filtered that way. That'll put a higher concentration in the body, and hopefully the sperm will swim in the right direction to where they're supposed to go. But most studies show that that is increasing your success by about 5%.
Wow.
So, you know, like I said, I will do anything a patient, I will meet them where they are, but we all have to be very cognizant of the data and being very thankful when it does happen, but also being understanding when that cycle doesn't end up to what we wanted, because we understand that the statistics of it are that we'll end up needing to do multiple cycles to probably get to the baby. And if not, you know, IVF may be something that we have to try. And what most people should really take away from this conversation is that the workup, the diagnostic workup, either if it's with your OB or with a specialist, is generally covered by your insurance. So at least understanding what's going on, even if you don't move forward with treatments because they're expensive or, you just don't want to utilize treatments because of whatever your belief system is. Understanding what the underlying cause is can really be helpful and provide you with some good clarity.
Yeah. This is great. I love this. I feel like I have so many people that come to me, including not even just patients. I mean, friends,
My
family.
line is already blowing up just in this. I'm like, oh my
Yeah.
God.
So I really feel like talking about where you start, or even just normalizing this, you know what I
Yeah.
mean? Because I feel like conversations like this are important so that more people can understand that this is a normal thing. This is very common. A lot of patients have to go through me as an OBGYN and end up with you as a reproductive specialist to get to their goal. So I just wanted to talk about that today. And I'm so glad to talk to you about it and to get some insight from what you see every day and teaching me a little something too, I'd love for you to come back.
Yay!